We thank you for your faithfulness. Thank you for thus far. Lord, we pray that as we begin today, day 2 of our symposium, we pray that you're going to be with us. We pray that we'll have enlightening discussions, and we pray that we shall have a good time. Those who are coming, may you hasten their footsteps, and Lord, may you be with us throughout the sessions and even tomorrow. And it's in Jesus' name we do pray and believe. Amen. Thank you. So today in our morning session, we are having two discussions. The first discussion will be on role of UoN pharmacists in patient-centered pharmaceutical care. We have a number of presenters ranging from academia to hospital to PPB to community pharmacy. People who have done a lot of impact, and all of them, I'm glad to say, are UoN pharmacists. So we are blessed to have Dr. Irene Weru, who is an oncology pharmacist at Kenyatta National Hospital. We are blessed to have Dr. Christabel Haemba, pharmacovigilance and patient safety at Pharmacy and Poisons Board. Dr. Peter Karemi from academia, University of Nairobi. Professor Francis Ndemo, MTM practitioner. Dr. Tabitha Gishuru, patient safety and quality assurance from Aga Khan Hospital. Dr. Sami Thwita, community pharmacy practitioner, and Professor Gabriel Kigen from Moi University. So these presenters have done a lot of impact in terms of patient-centered pharmaceutical care, and I know that we will learn a lot on how to have impact to our patients. So without further ado, I want to welcome our first presenter of the day, who is Dr. Irene Weru from Kenyatta National Hospital. So Dr. Irene Weru, welcome to the stage and podium.
All right, thank you so much for the introduction. All right, I'm really honored to be here today, and just for the invitation to come back to UoN. I'm always here because I work at the Kenyatta National Hospital. In 5 minutes, just thinking about summarizing a 20+ year career was going to be very difficult, but I chose to just tell you a story through pictures. So stay with me. This is where it started. I don't know how many of you have your university admission letter. So I received my university admission letter. It was dated 25th September 1996. And you can imagine those letters used to come through the post office box. So for me, really, this was an exciting moment. Nobody in my family had ever been to the university. So I've kept this letter. When I retrieved it this last week, my family, my husband and my sons were actually quite amazed. They said I'm a hoarder, but that's a special letter. And the picture you can see there is of my classmates. Some of them were here yesterday, Dr. Moneki and Dr. Karara, and they made their presentations. This is a group where when we were in the university, the message that we took home is to be change agents. That was the message. And the picture you see there, we had our Zoom meeting recently, probably a year or two ago, because our classmates are scattered across the globe. They are all over, doing amazing things and great things, some serving in public health. There are those in hospitals, there are those in academia, but I chose a path. And that's a picture of myself, gowned, and there's a biosafety cabinet behind me. So I work at the Kenyatta National Hospital, and at the Kenyatta National Hospital, we have a division of pharmaceutical services headed by a director, and we are divided into four units. I have displayed them there. You will allow me to look at my, so that I'm not turning. So we are divided into 4 units, and coincidentally, the 4 units are all headed by UoN School of Pharmacy alumni. So we have a unit of pharmaceutical products that basically deals with procurement, supply chain, budgeting, and quantification. We have a pharmacovigilance, drug and poison information unit that's headed by a specialist who I think were classmates with Dr. Kaemba, who will be presenting from the board. And that unit really looks at all medication safety related issues, medication error documentations, and looking at risk and opportunities for us to improve the system. We have pharmaceutical production that's doing great work, headed by a clinical pharmacist currently, but doing amazing work in terms of extemporaneous compounding, IV admixtures, etc. And then I head the clinical pharmacy unit. So our practice is guided by our standard of operating procedures, and we have work instructions. Then we have interprofessional collaboration, which is really key in terms of delivering patient-centric care. We have our pharmacists participating in clinical teams. We have pharmacists participating in departmental quality assurance committees across the hospital. And then, of course, we are the premier training hospital for the country. I know many pharmacists and pharmaceutical technologists as well at KMTC, UoN, and even other universities are coming to us for training at BPharm level and at postgraduate level as well. And we participate in research. We contribute even to the clinical trials that are happening at UNITID, as well as other clinical trials happening at the university. Currently, our pharmacists are contributing to the hepatocellular carcinoma clinical trials, breast cancer clinical trials at UNITID, and the vitiligo clinical trial at KNH. Among other clinical trials, there are so many at CCC, etc. And we are at the forefront of national health policy and formulation. This week, we have one of our pharmacists in Nakuru contributing to the review of the cancer treatment guidelines. So what's my story as a person? I can say many things about myself, but some of that is summarized in some work that I have done, the Footprints project with Dr. Othiambo, as well as the Young Pharmacist Diary with Dr. Marianne Ongundi. The picture where I have someone next to me with PPE, that was my first international meeting that I attended, and it changed my perspective on how pharmacy is practiced around the world. The other picture that you see with one of my mentees who received an award last year for research work that we had done at the Kenya Society of Hematology and Oncology. So my life really can be summarized in interprofessional collaboration, which is really key. You cannot work in isolation. You have to work with other healthcare providers. And my key areas of practice are in oncology, medicine management. We did some work with Dr. Mukoko on the Kenya Essential Medicine List and National Formulary, and in research. So those are my three key areas that I work really closely on. And what drives me is striving to be a 7-star pharmacist. Yes, a caregiver working at the hospital with patients, a decision maker. Every day we are making decisions on the lives of our patients, and other decisions as managers and as leaders in the hospital, communicating with other healthcare members, communicating with our students in training, a lifelong learner. I attend many different meetings, even just presentations that our own students make sometimes, just to learn and to grow, because there's no end to learning. And then I'm a teacher and I love it. And that's why I put there the picture with my mentee, Dr. Jean Kasudi, because we did amazing work with her, and I'm really proud of the work that our students do. One of our other students who should be graduating this year, her abstract has been accepted at an international meeting. And for me, being a teacher is quite amazing. And a leader, I'm a leader in my institution, but also a leader internationally, because the message I want to give to us today is that you can graduate from UoN and you can be a leader internationally. I have been secretary of the International Society of Oncology Pharmacy Practitioners, and I am currently the education chair. My 2-year term ended in April, but I took up new responsibility, and also the founding chair of the Oncology Pharmacy Society of Kenya. So in terms of advocacy, we have advocated for career growth. When we were employed in Kenyatta, there were limited opportunities for employment for pharmacists. We only could employ, I think there were 18 pharmacists, but we have done a lot of advocacy work, and now we can employ up to 40 pharmacists. And I want to just end with that picture. I know we are celebrating 50 years of excellence in pharmacy training and practice, transforming healthcare and shaping the future. I end with that picture. And I've canceled the 50 and put 29 because I joined UoN, like you saw from my first letter there, 29 years ago. So my years of training, my years of back for masters and work has been a whole 29 years. So that little girl growing up in the east of Nairobi, I would never have dreamt that I can go to the global stage. And the last picture there projected with two of my colleagues from ISOP was taken this last April at an international conference where we have co-published work on the global service levels for oncology pharmacy practice. And we are hoping that the work that we have published can be used for advocacy across the world to ensure that oncology pharmacy is actually recognized and a protected title where we can create more opportunities for our pharmacists, not just in Kenya, but around the world. So thank you so much for listening.
Another round of applause for Dr. Irene Weru, who is doing exceptional work in oncology pharmacy. Thank you so much, Dr. Irene Weru. Our next presenter is Dr. Christabel Haemba, Pharmacovigilance and Patient Safety Lead at PPB. So welcome, Dr. Christabel Haemba.
Good morning, everyone. So as you've heard, my name is Christabel Haemba. I don't have very nice pictorials as my mentor has just presented, because when I was doing my internship, she was one of my supervisors. So I just, sorry. So just a brief about my journey in the field of pharmacy. So after my internship, I was posted to Nyamira District Hospital, where I served as the hospital pharmacist and also as the district, because that time we were calling them the district, so district pharmacist. And one of the key things I was involved in, especially that's the time when HIV care was just being rolled out through the government. And I contributed working with, and I've seen Dr. Mukoko, and at that time we had MSH supporting what they were calling ARV sentinel sites, because you only had like ARVs within the district hospitals, but then we devised a way where we would cascade them down to the health centers. But I'm glad that right now, most of even those health centers are fully fledged ART sites. And then in 2009, I served as a medical superintendent in Ahero Sub-District Hospital, where I doubled up as also the district pharmacist. After that, I got the opportunity to serve as the provincial pharmacist in Nyanza. Then I ended up at PPB, where I worked as a regulatory pharmacovigilance officer. And then in 2012, I joined University of Nairobi for my master's, and we were among the pioneer class which did masters of pharmacoepidemiology and pharmacovigilance. I was later posted back to PPB, where I served as the head of pharmacovigilance. And then I got an opportunity to join Karolinska Institute in 2018, and I successfully defended my PhD last November. And Professor Gwantai was one of my supervisors with Professor Oluka. Currently, I've been appointed as the Deputy Director for Product Safety. So product safety looks at clinical trials, pharmacovigilance, and post-market surveillance, and medicines information. So I've also been able to serve in international committees within the African Medicines Regulatory Harmonization, where I served in the Technical Committee for Pharmacovigilance and Post-Market Surveillance within the East Africa Community and the IGAD Regional Economic Bloc. And then I served also as the International Society of Pharmacovigilance African Chapter Vice President between 2019 and last year. And currently I'm serving in the AUDA-NEPAD Technical Committee on Capacity Building. So how do I fit in terms of pharmacovigilance and patient safety? So just a brief history on how pharmacovigilance has come up in Kenya. So in 2004, we had the pharmacovigilance department being officially started in Kenya and at Pharmacy and Poisons Board. Then in 2009, we had the launch of the National Pharmacovigilance System. And this saw the rollout of guidelines and tools, because at that time, I remember the then DMS, Director of Medical Services, Dr. Kimani. So there were issues that some patients were getting severe adverse drug reactions related to use of stavudine. But then he said there was no data to show that this was actually happening. And therefore, there's no way the country will just change guidelines. And with about 15 reports that were collected after sensitization that had been done, Kenya joined the Uppsala Monitoring Center as the 98th full member. So with this, in 2010, the guidelines were changed and from stavudine as a first line to tenofovir. And then in 2014, through the efforts that Kenya had done, not just within the country, but also within the region, it was recognized and designated as a regional center of excellence in pharmacovigilance regulation within the region. So other things that have come in between that, we have guidelines for marketing authorization holders, which requires that each market authorization holder must have a qualified person for pharmacovigilance. And in 2020, through collaborative efforts between PPB and University of Nairobi, we launched an undergraduate pharmacovigilance curriculum, which is currently being implemented. Then we have a pharmacovigilance electronic system that has undergone quite change from the time it started up to now. So what governs the implementation of patient safety activities? So we have legal provisions. So in 2022, we had the gazettement of the pharmacovigilance and post-market surveillance rules, which gives PPB the mandate to set up pharmacovigilance systems. So we have guidelines, we have a reporting tool, and we focus also on patients. So when you go to the system, there is actually a part where the members of the public can also report, because we take cognizance of the fact that patients are a key stakeholder in healthcare. So it's important that they're also engaged. So, and you cannot work in isolation. Collaboration is key, because through collaboration, that's how you're able to work together and listen to each other's opinion, because it all matters when it comes to patient safety. So we have a pre-service training curriculum, the one I've just said, that was launched in 2020. And we've been involved, like personally, I also teach the undergraduates. I usually come for some sessions, and the master's students. And then we have an in-service curriculum, which we've also implemented and in collaboration with the University of Nairobi. And then through the rules, we have successfully had the designation of 47 pharmacovigilance and post-market surveillance focal persons. And most of them are actually also alumni of University of Nairobi. And majority of them have also gone through the EpiVigil, the Masters of Pharmacoepidemiology and Pharmacovigilance program. And we have 2 representatives, that is at KNH and MTRH, who are also graduates of the EpiVigil program. And just to add, during COVID-19, we had the recognition of the graduates of the EpiVigil program within the county, where we had a letter signed by the Director General of Health, and they were recognized in the counties, and their efforts are actually being appreciated in terms of managing patient safety. We also have safety advisory committees, that is the Pharmacovigilance Expert and Advisory Committee, and the National Vaccine Safety Advisory Committee, where PPB co-chairs with co-secretariat with the National Vaccines Program. And again, we have University of Nairobi School of Pharmacy alumni who are members of this committee, and they are working hard to ensure patient safety. We also have a PV. So we have a pharmacovigilance and post-market surveillance technical working group. And through this, we've ensured that all the public health programs have pharmacists who've been appointed. And this goes a long way in ensuring that we take into consideration what patients are supposed to have, and we make decisions that are evidence-based. So on the international front, as I mentioned, Kenya is a member of the Uppsala Monitoring Center. So the data that we collect is actually part of data that is used to generate signals. And this is what guides the WHO when they come up with guidelines that we are given. Maybe they are changing from one molecule to another. And then through the AUDA-NEPAD, African Union Smart Safety Surveillance, Kenya is among 12 countries that have been implementing and the monitoring of specific drugs, especially new introduced drugs. And within this project, we did cohort event monitoring during the implementation of COVID-19 vaccines. And we collaborated again with the University of Nairobi, and we implemented this in 17 facilities within the country. And through this, we have a joint signal management team, which again, we have Dr. Gwantai as a member of that team. So as you can see, University of Nairobi alumni are making a difference not only in Kenya, but across the world. And currently, within the African Medicines Agency, we have colleagues who are also serving within this technical working group. And then through the Proforma Project East Africa, which sponsored my PhD, we've been able to strengthen pharmacovigilance surveillance in neglected tropical disease program. So as the name says, even pharmacovigilance and safety monitoring was not a priority, but this is something that is now being implemented. So in terms of social advocacy and public sensitization, we collaborate with different associations. And these are just some of the pictorials during the past World Patient Safety Days, where we invite also patients, and then they talk about their concerns in terms of medicine safety, and we share. And sometimes we even have skits where we actually act out things to do with patient safety. Then we also have public sensitization. So sometimes we have articles on the newspaper. We keep also our social media pages activated so that we keep on updating the patients, just reassuring them on why it's important for them to report whenever they have any issues in regard to use of their medicine. So as you can see, there is a lot in the field of pharmacovigilance. It's not just about reporting adverse drug reaction. The scope has expanded, and currently we are looking at medication errors. We are looking at incidents that occur with medical devices. And for the final year students who are just coming out, as you can see, PPB has tried to expand the scope, like their job opportunities now are the market authorization holders. And then for all the clinical trial sites, it's now also a requirement that they must have a clinical trial pharmacists. And these are all efforts that are being put in place to ensure that patient safety is one of the key components in healthcare. Thank you.
A better round of applause for Dr. Christabel Haemba. Thank you so much, Dr. Christabel, and God bless you for the work you're doing at PPB. Our next presenter is Professor Francis Ndemo, who is an MTM practitioner. So I want to welcome him to come and give us his experience, vast experience, not just in Kenya, but also abroad. Welcome, Professor Francis Ndemo.
Good morning. Actually, I didn't make any PowerPoints because I saw 5 minutes. I wasn't sure whether it's going to be elaborate presentations. So I'm apologizing because Dr. Weru and Kamba did a very good job. Now, what I'm going to do is just to tell my story, or where it all began and where I'm heading. Let me put a caveat here. I'm not a product of University of Nairobi, as it were. I was never trained here. I'm much older than you guys. but I will explain how I ended up in University of Nairobi. Actually, I was trained here in high school. I went to Strathmore, and everybody else, all the parents wanted us to do medicine and so forth. And indeed, I got a scholarship to do medicine in Ibadan University. We were going there with the late Professor, your former BC, George Magoa. And again, he also encouraged me to apply for scholarship to UK. He actually got admitted to do dentistry and also got admitted to do pharmacy. So you can imagine I had to decide whether I should go for medicine or for pharmacy. But anyway, to cut the whole long story short, I ended up, I put that question to vote. Were 6 of us students in Strathmore. They all voted for UK. So I just went off to UK. And again, after my BPharm, this was in Leicester School of Pharmacy. I also trained in London for my internship of registration. I came back, joined Dow Pharmaceuticals, and but then I wasn't sure whether it was the right career for me. So I ended up applying to University of Nairobi, and Professor Maitai was very excited because I was the best student in pharmacology, and actually the best student overall for my class that year. So after that, I applied for Fulbright scholarship. I was very, very lucky. I also got one to do a pharmacy, my PharmD, Dr. Pharmacy in University of Minnesota. So let me try and explain what I've done so far as far as MTM is concerned. So you can imagine I really wanted to do something that's closer to the patient. Because I remember even the Fulbright Foundation, they gave me a number of options, PhD in PharmChem, PhD, so many PhDs in pharmacy. They were also not quite clear about this new program, the PharmD program. But I actually told them I wanted to deal with patients. So when I finished my doctor of pharmacy, University of Minnesota that was in 86, and did a fellowship also in clinical pharmacokinetics, I actually came back. And I believe I was the first one to be trained as a doctor of pharmacy in the University of Nairobi. But there were other PharmDs there, Dr. Njoroge, Kanambu, the first 2 PharmDs in the country, actually. I believe I was the 3rd Kenyan to be trained as a PharmD. So you can imagine I didn't have any mentors or any peers to guide me. So I decided to introduce clinical pharmacy as a course. With the dean, we were able to introduce that, and you can imagine that's grown. Later on, actually metastasized into MPharm as a graduate or postgraduate degree. But my first experience, so that I can focus on what I'm doing right now, is I joined the nephrology unit in Kenyatta National Hospital, where I rounded as a clinical pharmacist. Then later on, I was appointed by the late Agri Nyong'o in Nairobi Hospital to provide therapeutic drug monitoring, because that was my specialty areas. So you can imagine I was in an area where I didn't have a mentor, and it was very challenging. Actually, even when we used to do rounds, they didn't know what to expect from me. And but there's only one day when I think one of the medical doctors, bumped into Kodan Kimbo, the therapist book. It is this big. He actually took it and never gave it back to me even up to today. No, seriously. They didn't realize that we actually learn about diseases, the pathophysiology. I mean, I'm just saying, they just didn't know. And I remember trying to explain to them that have you ever thought on how pharmacists actually make medicines? They have to understand the disease mechanism, and then that's the basis for therapeutics. That's how we make them. So we the same people, just that our emphasis is on drug therapy. So, but anyway, so my first experience in Nairobi Hospital, I worked there for like 5 years as a consultant, and my challenge I had there was the salary. They tried to pay me, compensate me as a pharmacist, not as a medical doctor. So because I don't deserve, you can imagine. Some of us, Kijombai, I went back and told Professor Nyongo, it will never just show me why my intervention is any less important than that of a neurosurgeon. That was actually my argument. I remember in Nairobi Hospital. And I told them I make a difference. You people rely on me. And I had the initial challenges. Why does Dr. Ndemo need all this information? Does it need it? Is a pharmacist? I said, no, I need to know all the demographics, the comorbidities, everything before I make any decision. And eventually, they allowed me, and I was in the list of doctors, and I was being compensated. I got good money. I was, at least, I was actually, no, I was getting an average of 120,000 shillings, that time was a lot of money, actually. And even monitored very senior people without naming names. And there I was. But later on, they came to accept me. I told them, I'm not fighting with you. So after that, I left for the US. Remember, you asked me to talk about my experience in the US. When I took off, I was appointed as an associate professor at Creighton University. Again, I was there for 2 years. I was teaching pharmacokinetics. But my clinical practice truly started when I went to Hampton University in Virginia. Here, we actually set up 2 clinics. I was there with Dr. Ombengi, who's now in South University. We set 2 clinics. I started teaching pharmaceutical care. This is where the story began about pharmaceutical care. I went and I got a program from my University of Minnesota. It was called an assurance program. And we're actually using it for monitoring patients. Essentially, I know you're very keen. I'm talking about the 5th-year students. It took me a little while to understand there's such a thing as pharmacy practice, what the practice is all about. I realized, for me, I know most of you may not agree with me because you're not providing MTM, but the practice involves the client and the professional. The client and professional make a practice. In other words, pharmacy we do many things that are not what you call direct patient services. But the actual practice, the way it was defined in my university was, in fact, when you deal with the patients, you try and identify their problems, resolve them, and try and prevent them. That is where we are right now. So the philosophy for those who actually provide direct patient care is that their responsibility is to identify, resolve, and prevent drug-related problems. When you're talking about drug-related problems, we actually call them drug therapy problems sometimes interchangeably. And essentially, to understand what I actually do is we normally will ask patients to come with all the medications. I'll go through the 1 or 2 steps. Then I'll summarize or wrap up what we're doing here in Kenya. So what we used to do is, for me, I used to take like 3 PharmD students. They could go through the charts and try to form what you call the patient medical problem list. Then after that, we try to see if they are at goal, whatever is being managed. If they are not at goal, then we try to find out if it's drug related. And eventually we come up with a care plan and then follow up. But of course, the things we used to do, we used to give what you call a medication action plan to actually tell patients what they need to do to improve their drug therapy outcomes. So that was in the US. And again, it's because of the 5 minutes. I'm just trying to rush through. I was very passionate, by the way. Eventually, I had a couple of awards. I was a clinical preceptor of the year. I also won. There was, oh, there are many. I forgot about. I also won a national award for my research that I did in kinetics. You can look it up. Another one was an excellent award for as an educator at Hampton University. So when I came back after being there almost for 20 years, I joined the University of Nairobi. I was here for 2 years, and then I set up the MTM clinic here in the Fortis Suites. And one of the earlier guests, I can see she's my mentee, Dr. Susan Mageto. She knows why she's smiling. She knows that she had randomly walked into my office at the clinic. And that's how her academic journey started, because I persuaded her this is the way. But anyway, essentially, what do I do at the clinic? It's very important. I believed image is everything. I practice as a pharmacotherapy specialist and as a doctor of pharmacy. You wonder why I shied away practicing as a pharmacist. So, and that is why I've been pushing for this program, the doctor of pharmacy. A lot of guys, I'm not here to promote doctor of pharmacy. It's conceptually, it's a practice-based doctorate. You're there as a doctor of pharmacy and physician, and there as a doctor of medicine, and others are doctor of dentistry. A doctor of dentistry, DS, and others doctor of nursing practice, etc. So really, it's in the future. I'm seeing a future where we have a big role as actually clinical practitioners. So what I do here at Fortis, I see patients, and in fact, I've never advertised, but the word came around. There's a professor there who can actually spend time with you, and because it makes a difference, I have a database of almost like 100 patients. You actually see them, and the good thing, they come and sit and wait. They have never seen me dispensing a drug, right? I dispense information. I don't deal with, I don't mean the drug product, there's anything wrong with it. But honestly, Dr. Moed can tell you, you come and sit. If you want to watch TV, you can watch. Literally, it was a model for the other pharmacies to emulate. So, and I earn a living from it, actually, for now. Now, what do I do so that I would have done a better job. I thought 3-4 minutes of my experiences. Now, what have we done? I've been a chair, or rather I was the past chair of the training and assessment technical committee of the board. We have worked on what we call the GPP, the Good Pharmacy Practice. It's guidelines. They have not been gazetted yet, but we went through all about 30 standards, and we have addressed the clinical component of MTM. The other thing we have done, I've been fighting for the pharmacy benefit package with SHIF, is it SHIF or SHA? Whichever one. What there is, if there is any important information that I will give you today, is in the States, in the United States, they have been fighting to actually be recognized as healthcare providers. You may wonder what is so unique about being a provider. Providers, they are recognized by insurance and they're compensated for their work. And that is, imagine all these years, they're not. Even in this country, when they talk about healthcare services, they will talk about physicians, they refer them as doctors, nurses, and what have you. And then the other issues is drugs. They don't talk about pharmacists. They talk about, even actually our Cap 244. They don't talk about pharmacy practice. I don't know whether you have ever realized. It's Pharmacy and Poisons Act. There's no practice there, Dr. Elizabeth, you look at me. There's no practice for sure. It's now probably they want to talk about a practice council, Pharmacy Practice Council. But otherwise, there's no practice. What am I saying? The message here, when I went to SHA, I wanted, what do you call it, a service model for pharmacy. In other words, we provide a service in addition to a product. It should be compensated for. That's why, because of the perceived role of the pharmacists, that's why the pharmacists are not being employed by the counties and whatever, because whatever you're doing is the same thing can be done by farm techs. But now I'm talking about the cognitive services that we provide has to be provided for. So I was glad Dr. Kemba was talking about medication safety. It was a big issue recently in a workshop in Naivasha about patient rights. And what I was proposing for, we already have people have done pharmacovigilance, but in the UK, another place, they have medication safety officers. Pharmacovigilance, okay, for me, you may correct me on this one, I was thinking of, from a public perspective, you collect data and see trends and make decisions. But medication safety officers will actually be immediately responsible within an institution and respond to issues internally. So, so with that scattered presentation, my dream, and I'm very grateful for University of Nairobi, even though I was never their product, but I've been a manufacturer of their products for many years, 19 years. And Professor Wanta is very much aware. We're trying to push in the clinical component, and the farm chem holders really fought us back. But I think eventually, I hope, but right now they're being baptized. So Prof, they have actually, a lot of pharmaceutical chemists, they've been to US, they've come back, they're a little bit baptized. So my dream truly is to know that to overshadow the other areas of pharmacy, but I'm just hoping a pharmacist will be seen as a healthcare provider, and the population will be sensitized. Things don't end up with a prescription. Actually, things begin with a prescription. You know, where the intervention. You know that. Some of us who have been here, you know, Prof, we have been arguing, we are the intervention. So truly, I may even argue we are the doctors of medicine. I mean, I'm just saying, seriously, we're talam, nisizi. Always saying, and everybody does, the medical doctor do a good job, but the pharmacy could do a very fantastic job. So my message truly is to see where there's a change of curriculum so that we have enough teacher practitioners to mentor our students and become good people in the future. Thank you.
Thank you so much, Professor Ndemo. Another round of applause for Professor Ndemo. Thank you so much. So allow me now to introduce Dr. Tabitha Gishuru, Patient Safety and Quality Assurance Officer at Aga Khan Hospital. Welcome.
Good morning, everyone. Sorry, just like Prof. Demo, I thought 5 minutes were too short for a presentation, and I think I can actually talk through what I wanted to present on. So I'm from the Aga Khan University Hospital, where I have practiced for the last 25 years. 20 of the years I actively worked in the pharmacy department, where I worked in different portfolios. But I would say my most interesting one, where I felt I made a great contribution, and this is when I thought about the quality and the safety of the patients, and also the safety of the staff, is in the setup of the IV admix unit, where reconstitution of chemotherapy products are done. It used to sadden me walking around in the ward, and there's a time I found a doctor reconstituting chemotherapy and then threw the remains in the dustbin. And I asked her, Daktari, are you thinking of the person who is going to handle this? Are you thinking of the fumes and what you are doing to the other patients? And that became a journey for me, where I negotiated with the management. I did an in-service training in one of our sister hospitals in Pakistan. And I was able to set up that unit where we do IV, the reconstitution of the chemotherapy products. Also thought of other products which are quite risky to the patients, like concentrated electrolytes, where we find people giving KCl concentrated. And we also do reconstitution of that so that you give to the nurse when it is prepared. And also antibiotics, where you want to do the correct calculation of the dose so that you give the patient a product, the nurse, a product that is ready for use. And also have moved on to nutritional products, especially for the pediatric population, where we don't have something in the market which comes ready-made. But after my journey of 20 years, I had an incident once where I called a doctor, and I wanted to discuss with him about the medications he had prescribed, because it was a concoction of so many pain medications. And the doctor told me, what does a stupid pharmacist know about a patient sitting in the ward? What do you know about the pain? So I thought about it and I didn't take it as an offense. And I actually took, like, this doctor is saying, as a pharmacist, why don't you come and we work with you? Instead of you being in the pharmacy where you talk to me over the phone, why don't you come and work with me? And I started thinking of how do I work with the other practitioners within the institution to actually make the care better. And I got an opportunity to work in the quality department within the hospital. And when I said I wanted to work there, people didn't know really what I was meaning. They asked me, are you sure of what you wanted to do? And I knew what I'll do as a pharmacist once I go to that department. So for the last 5 years, I've worked in the quality department, where I have worked in various areas, surgery and anesthesia. Currently, I'm working in the Department of Medicine, where I'm a quality advisor. Maybe just talking a bit of quality before I come to say exactly what I do. We know there are many attributes of quality. One of the things we greatly think about when we talk about quality is the safety of the patients. Remember, there are times we can actually end up causing harm to the patient. You can have medication error. So as much as you wanted to do good to the patient, you end up doing harm. So how can we prevent harm happening to the patient when you actually wanted to do something better to the patient? The other area is on timeliness of the care that we give to the patients. Sometimes we give care, but the care is delayed. Maybe sometimes you don't have, and I talk about us pharmacists, you don't have the medication that a patient needs. I don't know whether this really still happens, where you hold on to a prescription as you try to source for a medication. So what is this doing to the patient, the delay that you're having? So one, are you having a conversation to the patient? Are you telling the patient that I'm delaying your care because of this and this and that? And you're able to educate them and they make an informed decision. Am I going to wait, or could I go and source for this medication elsewhere? The other thing is the efficiency of the service we give to the patient. And when we talk of efficiency, we think of overuse and underuse. I know so many times we talk about antimicrobials. Sometimes we can end up overusing a medication where you really do not need to use the medication. And there are also times we end up underusing, because you really need to use this medication, antimicrobial agent, but you're not using. So that also forms an area of quality. The other one is effectiveness. What we are using, is it really effective? Are we still practicing medicine of 1970s, or are we using the newer guidelines, the clinical practice guidelines that are there? Are we updating ourselves every day so that we are up to date with what we are doing? Then there is the issue of equitable care, whereby the care we are giving to the patients, are we giving equal care to all the patients we are getting, such that I'm not giving you better care because I see you are better dressed? Are we giving equal care to all the patients that we are having? And the final one is the patient-centered care, where we invite the patient, can you come and you be part of the care that I'm giving to you? I do not want to say, just as we are being told when we are young, Daktari has said, you take this capsule and do not take milk. And you didn't know, I mean, why am I being told not to take milk? So you want the patient to be part of your care, such that if I say, as a patient, I want to take the milk. So how do I tailor your medication? So you want to invite the patient so that the patient can be part of the care team. And in that way, they are able to participate and even adhere to the treatment you're giving them. So that is about quality and patient safety. So what do I do? My work entails being part of the team that actually does prepare the policies. Remember, that is where the whole journey begins, that you must have policies that are guiding the practitioners, both the clinical and the non-clinical staff, in how they are going to practice. And not only making that, but also doing the training to them. This is my work, day by day, training them on this. And the policies that we do make, one, they are guided by the best practice and also by the quality standards that we have subscribed to as an institution. In my institution at the moment, we have a number of accreditation. So we've actually subscribed to a number of those standards. So we ensure that the policies are actually geared towards that. And then finally, after you have taught the people and they are practicing, how do you ensure that every day they're actually doing as per policy? So my work also entails auditing, where I can decide today I want to trace a patient who came into casualty, went to ICU and maybe died or didn't die and went home. I can decide to trace that patient and see what was the care that was given to this patient. In casualty, they were given the medication. So the nurse gave a pain medication. Remember, we say the patient should be free from pain. So if a patient came and said my pain score was 7, so what did the nurse give? Then if they gave the medication, did they ensure the patient after that was free from pain? So I want to go and see, did they monitor this medication? We have said for IV medication, after administering, after 15 minutes, you need to go and monitor. Is the patient free from pain or has the pain reduced? So that forms part of our work throughout the journey. Were they using the right kind of medication? Did the nurse actually administer the medication? Because one of the things we have seen, and those who work in hospitals can say this, somebody can sign they gave the medication. So did they actually sign for the medication, where you can even go and talk to the patient and find out, okay, why you given this medication? So that forms part of the journey. We can also decide to audit a product, where I want to follow up a product. There's this medication that was used on a patient C in ICU. I trace this medication. How did this medication come to the hospital? So before it came to the hospital, how was it stored wherever it was gotten from? Trace the whole journey through the transportation and how it has been stored within the hospital until the time it was used by the patient. So this becomes a whole journey. I'll be able to audit the physician's chart to see actually how was their decision. Was it the right decision for them to give this kind of medication? And then we also do participate in what we normally refer to when we have patient safety events. For example, a patient may die, or maybe an incident may happen where you think maybe, or a patient has come back to the hospital 24 hours after they were discharged. That is not normal. So we normally conduct what we call root cause analysis, and that is part of my work as a quality advisor, where I'll be able to analyze, call the teams together, and we actually talk and see, was there a gap in the care of this patient? We'll be able to dig down. Was it the medication? Was it the right medication? Was the patient actually given the medication? Did they take the medication? And from that, as a team, you'd be able to come up with action plan. And one thing we did with, we inform people, and which we try to fight for, is a culture of safety, where as a practitioner, somebody would actually be able to say, I didn't give that medication. I was supposed to give 2 vials and I gave 1, and there is no punishment for that, so that we can be able to improve. Remember, quality is a journey. It's not a destination, where every day you are able to seek how can things be done better. So we come up with action plans which are implemented. And again, I go down to the ground to see the validation of this action plan. If we said a policy needs to be changed, if we said somebody needs to be trained further, have these things being done. And in that way, it becomes interesting when you know that the quality of services or what we are giving to the patient is safe, and to ensure that our patients are safe at all times. And part of the interesting work that I've done, I've been involved in auditing a number of hospitals. I had the privilege of auditing Kudere Hospital in South Sudan, where they had actually called a team of us as consultants to go and advise them, not only in pharmacy as they set up the pharmacy, but also in the quality of care that you be given to the institution. And one thing that I would appreciate is that people do appreciate this. Today, if I walk into theater when surgery is going on, I can go and sit there and just watch. How are people managing the medications there? And one of the interesting things when I joined the Department of Surgery, I noted sometimes people could have this concoction drugs they have mixed. What is it that you have actually mixed? Are you labeling your medications as you are using them? Or can you come and confuse one medication for another? And these things are things that have happened. So I would say we have so much work as pharmacists, which we can do in the various institutions and in areas where people didn't want us to be before. I think we have the opportunity and we can do great things in our various institutions. So where do I want to be in future? I'm actually preparing myself, and my desire is to be an international auditor when it comes to issues of quality and patients' care, and that is what I'm preparing for. I'm actually a certified professional in health quality, and actually this year I'm going back to for a recertification in the same area. So thank you so much.
Thank you so much. Let's give another round of applause to Dr. Tabitha Gishuru, becoming an auditor of health. As a pharmacist, you can be an auditor of health. Now, let me introduce Dr. Sami Thuita, who is a community pharmacy practitioner. So I welcome him to take us through his presentation. Karibu. Let's give him a round of applause as he comes.
Good morning. Yes, Sami Thuita is my name. Graduated or joined the university in the double intake of 1987. So I don't want to count the years. I saw Tabitha saying 29. Mine are a bit scary, but of course, Professor is here. So let me not try to say how many years we've been out there. After my internship in this hospital with Dr. Wanyanga and our late sister Bilha, I posted to Nyamira and just reported, and I was scared by the distance, Professor Demo. So I resigned, and Dr. Moses Mwangi was waiting for me because I had applied a job where he was one of the managers, and he gave me a job. And the job that I was given at that point is because the company was transitioning, introducing some 2 new areas, innovator areas. One was in thrombosis and the next one was in oncology. And they needed a pharmacist who could be able to run with those 2 divisions. And so he took me there. And I'll very quickly talk about that before I talk about community pharmacy. In those 2 areas, when I got in there, we realized the area that needs a lot of attention is where the professionals will be able to help the patients. Because in thrombosis, we have, like Tabitha says, we have a lot of physicians and surgeons especially. They will do a great job in theater. The orthopedic surgeons will do a great job in theater. The ICU patients will be there, wonderfully taken care of. But one area that was not being focused on were the clots, the DVTs. And so we spent a lot of time educating our surgeons, and there was a lot of resistance. But thank God for the anesthetists. The anesthetists were ready to listen to us of the risk of those patients who had done those procedures very nicely, but just before they go home. And I remember some cases here in Kenyatta Hospital where, with the relatives who come there and see a patient who has had an accident, that they have gone through theater, they have been treated very well, and we bring them the chips and the chicken and everything, and they are telling us, tomorrow I am coming home, or you can come for me. And as soon as they have finished eating the chips and all the things that we bring them over lunchtime, and we have the relatives have gone home, the guy wakes up to go to the bathroom, and he doesn't return. They collapse. And I think that happened too many times. And so we wanted to educate the surgeons and anesthetists how to ensure that those patients are covered against deep vein thrombosis. It was a new area, and we did a lot of that work in that area. I remember the turning point was one very senior banker in one of the hospitals, private hospitals, with one of the senior surgeons, orthopedic, and he had done a great job with his anesthetist. And just when the lady is about to go home, that thing happened. And this guy, I have told him over and over, and he's telling me, I do clean surgeries, I give my cover for antibiotics and everything. What is this thing you're telling me about EVT? But the woman left us, And that was a turning point, because then the conversation among the anesthetists and the surgeons changed completely, and were able to change how patients were being focused on. I worked with James Mwenda there, was my young man then. The other area that I want to talk about briefly is oncology. Again, we were the first company to start focusing in oncology. And again, we had 3 oncologists at that point in the early 90s, 2000. Only about 2 oncologists were practicing. The others who were helping in were the hematologists. And again, there was the issue of very expensive. The products we brought in were very, very expensive. And we partnered with Roche. At that point, we couldn't see ourselves as competitors. Roche was bringing in support products for supporting those who are going through chemotherapy. But the main challenge, again, was for the patient, the side effects, how to deal with those side effects. And we found a space where we could be able to engage, and the doctors were very happy to have a pharmacist who can be able to spend more time, like Prof says here, with the patients to take them through how to manage the side effects. And that also came in with the relatives. So how do we walk through this journey? Because sometimes they try to call Professor Abinya, and he's busy with many patients. But at least then they can call me, and we can go walk through that journey of managing the side effects and the diet, because that was another issue. Because oncology patients, as you know, they are totally hit by the chemo, and eating is another big issue. How do we walk that journey of the side effects, the diet, and everything? And that was a beautiful journey when we helped that to happen. We helped the physicians, the oncologists, the pathologists to form an association called KESHO, the Kenya Society of the Hematologists, Oncologists. And in there, we're able to invite the pathologists, but we also encourage them to have cardiologists and a few other physicians. This is what I had seen in other countries, in South Africa, in Botswana, and Namibia. Cancer patients are managed by a team. When a cancer patient comes into an oncologist, it is a team. They have to call the team first to discuss. And that team involved everybody, the pharmacists, and all those other specialists, the pathologists, and everybody. And so I came and I shared during these conferences, the KESHO conferences, why we need to have teams managing cancer patients. And that was very well taken, so that now the doctors were able to discuss patients together. I met one of the professors yesterday, Professor Mwanda, and I was asking how that is still going on. It's there, but maybe not in the way that we had introduced it, because we wanted to see in those countries. Namibia has an excellent program for cancer patients, how patients can be the focus in terms of management, but not as one person, but a team. And that was one of our initial things that we did. After that, I left. Of course, I left the company in 2011, and I went into private practice. I mean, I ran retail pharmacies, community pharmacies. And I started with one that given by Dr. Moses Mwangi, because he was too busy out there, and he asked me to take over a shop that he had bought from another man before. And one of the areas, as you know, Dr. Moses Mwangi was a pioneer. I would call him the father of vaccination in this country. We know him. We know what work he has done. And one of the things he has done in that pharmacy was to set up a vaccination center. And so when I took it over, and that's the only area I'm going to talk about in community pharmacy, is the role of the pharmacists in vaccinology. And I think that's something that we have not, again, incorporated too well. I am not too sure how many are doing that today, any community pharmacists that are involved in vaccination. If you could put that picture. Okay, as he's doing that, so we have a setup, all my shops that I have, we have set up, and one of the defining characteristics of our business is vaccination. And again, when you go out there, you go to Australia, you go to South Africa, you go to America, people don't go to pediatricians except the initial vaccines for children. Subsequent vaccines are given at the pharmacy outlets. And that is really our role. Of course, there has been a lot of resistance, accepting that pharmacy can do this. And I've had many meetings at the Ministry of Health with the Director of Public Health, telling them, please, this is the work of pharmacists. And yeah, they say, yes, this is your work, and I know we accept it, but policies, as we have not been able to go all these input in guidelines, but we have continued to do it. We have been trained. Professor Guantai, at some point, they brought some teachers from the US, and we are part of that training program. And we have been able to see how you can impact healthcare through encouraging patients, especially our senior citizens, in terms of vaccination. The flu, for example, that is a common thing. When you get this old man or this old lady who comes all the time that they're having infections, we're able to tell them, you can actually be able to manage your costs by going through a flu vaccine. And of course, the food handlers, we also encourage them to go through vaccinations and all that. And that is actually the work that we understand as pharmacists. And so we have defined ourselves. Sorry, that picture failed to come. I wanted to show you one of our shops that is actually a registered vaccination center. And so I wanted to say that area in community pharmacy is something that I've just taken that this morning. I was in that shop. So as you can see, vaccination center, and lots of resistance, especially from the practitioners out there. They're saying, oh, pharmacy, you cannot do this. Sometimes when we do even our Stamaril, they go and they tell them this is not, but we have a vaccination center number from the Ministry of Health. We were given a number. They came and inspected our shops, and we were able to do that service. So today I wanted to tell you that as pharmacists, which I'm glad that it is now something that is being offered at the university, we are the right people to offer this service. We are accessible. Patients don't have to wait there for hours as they wait, maybe the hospitals. They can come in quickly and get their vaccination and travel. Like right now, especially those who are traveling, we are very busy with those who are going for Hajj or with all the travel vaccines that they need, and we're able to give all those. So for me, I wanted just to mention about that because of the time factor. Vaccination is an area for us as community pharmacists. We are accessible, we have the information. Storage issues, like Tabitha says, is an area that we're able to control and ensure that those vaccines are stored properly from the time when they leave the suppliers to the time they come into our shops. Managing the power issues that make sure that we are always keeping the cold chain completely managed. So it's our responsibility, and we are doing it, and I know we can all succeed in it. I think let me stop there. Thank you very much.
Thank you so much, Dr. Sami Thuita. Another round of applause for Dr. Sami Thuita. Allow me now to welcome Professor Gabriel Kigen from Moi University. Welcome.
Good morning, everybody. May I do something different? I teach medical students. Outside 3 minutes ago, I met one of my students. She's very excited. I should have brought her in here. She's a professor of gynecology here. Yeah, we just met 3 minutes ago. Now, I would like to thank especially oh, you Professor Sui, Dr. Sui. Okay, he was 1 year behind me. So I graduated here very recently in 1987. That's when I graduated as a pharmacist. After that, I went to work at UoN Hospital. I worked as a pharmacist. At some point, I was even the MOH briefly, which was terrible as a young man. And then I After that, I joined community practice. At that time, it was a struggle getting out of the government because you are bonded for 3 years. So it was because we had a lot of opportunities where what we could do. And then I joined community pharmacy for some time, and then I went back to academia. Now, I've been in academia for the last like 22 years. I teach at Moi University School of Medicine. Now, there we have done a lot of programs. Before that, I went for training in UK. That's when I had exposure for research. I did my PhD at the University of Liverpool School of Medicine. I taught medical students there. We were involved in a lot of research. That's the first grant I got, £4 million with my supervisor, because we were doing, we were trying to do nanomedicine and comparing with standard medicine, but I couldn't remain there. I had to come back home. I had a lot of issues to do here. So what do I do? Apart from teaching, I do a lot of research. So I teach medical students, both undergraduate and postgraduate. And at some point, I think I'll come to that later. We have a short of time, so let me try to, I don't know where to start. But let me just start. It's been, first of all, I'd like to thank my professor, Professor Guantai. I can see she's the only one in the team who taught me here. And our senior here was the chief then. This is a very good opportunity for pharmacists to be together. I interact a lot with the medical people. In fact, I had somebody in Aga Khan. I'll be there the whole week. We have an International College of Psychopharmacology for psychiatrists the whole week. And I'm one of the presenters. I'll be doing some presentations. Now, so let me talk about the pharmacists. I think we will address especially these young people. At some point within Eldoret, we have a collaboration within AMPATH of so many North American universities. And key among them is Purdue University. Purdue University is a school of pharmacy, and they bring their residents here. And thankfully, University of Nairobi, you have given us students who've come as interns there. And I am not sure if anybody here has been an intern. At some point, we thought that these interns are going to go out. There's nothing to show off that they have done our training. So we, with the assistance of MPRH, we did a curriculum for postgraduate pharmacy, and they trained the pharmacists there and other pharmacists to practice clinically. And that's how we started clinical practice at MTRH, and I think she knows it. All our pharmacists are involved in clinical care at bedside with the other team to make clinical decisions in real time. The things that maybe we taught, and even you people who have been taught, we implement that at bedside, and it had really brought better outcomes, and we work with everybody. Then we also thought that we should start a school of pharmacy, but we wanted, because we were going to do clinical, we didn't have preceptors. So we, through the Department of Pharmacology at the School of Medicine, we started the MPharm program, and I think we have graduated like 3 or 4 cohorts. And very soon we shall apply to the board to now start the pharmacy program, the undergraduate program in pharmacy. Our strength is in clinical practice, but that doesn't limit. I think we are very lucky because our profession is versatile. Versatile in that there are so many routes that you can take. You can take, like many people have said, I would not belabor in that. So outside that, the other opportunities which I want to raise, like I said, I'm also a researcher. I'm involved in a lot of research. both locally and internationally. I was trying to remember where. I think we met in Canada for, I don't know whether it was you or another, not in Canada, in Ghana, or clinical trial. So I've been involved in oncology clinical trials. We've also done research on hepatocellular carcinoma, where we got some funding from France, been part of the research. We have also been involved, which is still going on, for maternal and child medicine trials, where we were even trying azithromycin in labor to see if we can prevent sepsis, and we got very good results. We just published the New England Journal of Medicine. We've also been involved, we are still involved, I'm still involved now with the team at Aga Khan, where we are doing NeuroGap. We are looking at genetics of African populations in terms of mental disorder. We had I know there's a lot of politics now. We had a grant with, we are doing with Harvard, the Broad Institute of Harvard University. Why am I saying that? I want the young people to know that there's a lot of, opportunities, especially in research. I know you are young people. It made me travel all over the world, where you present, and it's very exciting. You can travel a lot. The other opportunities, what else did I want to, within to fit the 5 minutes? The other opportunity, and I'm happy our PPB people are here, is in the field of clinical care. In my view, the way we are working at MTRH, that's the biggest opportunity for pharmacists now. And we need to train a lot more pharmacists to practice clinically and to be involved in care. That is a huge opportunity. We may have to twitch training a bit to fit into that. And with that one, I'm sure we'll need more than even 10,000 pharmacists to practice that, both in the hospitals, as well as my brother here, what he has said, in retail outlets. There are so many other things that we can do apart from vaccination, anticoagulation clinic. We already have at MTRH a running pharmacist-run anticoagulation clinic, which is very, very successful. I know we are going into the age of, the other important thing is, we are going into the era of precision medicine. In other words, whereby drug, dosage is going to be based on genomics, patient genomics. So paracetamol is not going to be 2-3 times a day. It will be 6 for somebody else, maybe 1 for another. And that is very important in care. And that's a huge opportunity for pharmacists to practice as such. I think I will stop there. I hope I have not taken more than my 5 minutes. Thank you very much.
Another round of applause for Professor Gabriel Keegan. Thank you so much, Professor. Our final presenter is online, Dr. Peter Karemi, based at the University of Nairobi. So Dr. Peter Karemi, can you hear us? Are you ready? So as Dr. Karemi sets up, so please be ready for our next session. Our next session will be on the resilient pharmacists, taking unconventional paths. So once Dr. Karemi is done, if you have any questions, just hold them. We'll have a round of questions once we are done with the panel discussion. And Dr. Joseph Mukoko will take us through the panel discussion. But in the meantime, I don't know whether Dr. Karemi is ready. Okay, Dr.
Hello, Dr. Kabia. I can't chair. I think there's a problem. Can you allow me to chair?
Okay, so as we allow you to share, you can continue.
Thank you very much. My name is Karemi. I teach at the University of Nairobi. Clinical pharmacy. 1 minute for my background in the profession as a clinical pharmacist. I graduated in 1990. I've had some of my colleagues are slightly older than me. And the journey of clinical pharmacy to me started way back during my internship when I realized that there was a deficit where I was actually working and decided to go to the clinical areas. I would imagine that that time, of course, the course was 4 years. And I would wonder how would someone would just spend 4 years in the university just to go and dispense. So I decided to be joining the clinical areas to see what happens. I recall those days, it used to be very rare to see a pharmacist in the clinical area. Initially, of course, it was challenging as an intern, but alone, I was actually be able to get incorporated into the clinical area very well. I can assure you, my colleagues that time in medicine were very supportive.
Try and improve your internet or your
Until finally, I went now back to academia. And I'm happy to say that the pharmacy side has grown in the last about 7 years significantly, and in the clinical in the past. I've been listening to action is not clear. Career, can you hear me?
Now we can hear you. You can continue.
Yeah, I think there's a problem with the internet connection. It keeps on going up and down. So what I'm saying is that I'm happy now. As I traverse this country, pharmacists' involvement in the clinical areas has become recognized. And I take pride in the sense that gradually we have been recognized in the healthcare sector as healthcare providers, not just offering medicines, but in direct patient care. On my side, I feel honored. I've walked this journey, especially at the University of Nairobi, right from the inception. And I've seen the profession grow in leaps and bounds in the clinical care setup, where pharmacists have become decision makers. And in some scenarios, nothing can go on without the involvement of the pharmacist becoming a key player. So allow me just to share a few slides. And as usual, I will just start with a bit of background as far as pharmacy is concerned. Are my slides feasible here?
Yes.
Kagia, can you hear me?
Presentation mode. They are visible, but you can put them on presentation mode.
Let me see whether are they moving at the presentation mode?
No. Okay, you
Then
can.
allow me to move them like,
Okay.
are they moving now?
Now we can see. You can continue.
Okay, maybe let me zoom in a bit so it becoming a bit larger. Yes, so I was saying that my personal time, as I walk around, I found that these people have even gone higher because of their competencies. They've been given responsibilities, including the management, whereby they're actually managing hospitals now, bearing in mind that so ingrained in the clinical aspects of the profession, they understand, they have what you call the technical competence, as well as, of course, the managerial competence. So these people are involved in management of patients, they're involved in management of institutions, and also they are involved in other policy decisions, as some of those seated there can actually attest. Therefore, how you will find at the university level, we are actually involved in patient care. More so our graduate students, you find them in all areas of the hospital. And these people, they are becoming indispensable in a way due to the kind of care they are actually offering. In addition to that, when they specialize in the respective areas of clinical pharmacy, they have been trained to offer pharmaceutical care. And soon we are going to go to MTM full blast to ensure that they offer quality care. The University of Nairobi is working very closely with Kansas University. I've heard Twitter talking about vaccinology. A number of our students have actually been trained in vaccinology, and this is in relation to with Kansas University. And it has been accepted that vaccinology centers become part and parcel of the profession. And going forward, because of this chair that we are talking about, our pharmacy has been recognized as a health facility. Therefore, the direct patient care we are about to shall cascade all the way to the village level, where patients may not require to go for primary care in any other place beside the pharmacy around. So this vaccinology course has made a big impact in our country. Every year we train about 80 to 100 potential in the field, and if those who are still in the course has actually been there since 2014, whenever this course is actually being offered. Concerned, the academia, the university celebrating today, has really played a very big role and about what they require to do in the patient care area. So as far as the patient-centered care is concerned, the university is at the forefront, and we are doing our best despite the challenges that usually face any other institution. Now, regarding the profession, is what do we emphasize on most going forward? The first thing is, in my own thinking, is that the time that you spend in the clinical areas, in our health, in our education institutions should be enhanced. I'm thankful to say that the board has come up with a curriculum which will start teaching our students clinical aspects way back in the first year. And now this is important because pharmacy as a healthcare profession requires one to gain the knowledge and skills very early in life so that by the time this person graduates, he will be competent in how things should be done as far as pharmacy or pharmaceutical care is concerned. I hope and pray that when this curriculum comes into being very soon, all the education institutions that are training pharmacy today will embrace it because going forward, the only way pharmacists will be able to survive in the turbulent world is to make sure that they offer services that can be seen and can be appreciated and can be reimbursed, because that is where CHA is moving towards. We know, of course, that this aspect of pharmaceutical care is the cornerstone of the profession. As we handle products, because they're still ours, at the end of the day, the impact will be more when it's felt at the grassroots, when it is felt by the patient, and when it is appreciated by whoever comes into contact with the pharmacist. Right now, you have to agree with me that most people normally go to pharmacies, especially community pharmacies. They go there because they are seeking care at the pharmacy as a first point of contact. Nowadays, the issue of people just coming with prescriptions is not the case as it used to happen in the past. And therefore, you must be able to make sure that these people, graduates from these institutions, are so well qualified that they are going to offer quality care. Because it's the cornerstone of this profession, then, it is important that, 'cause, 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 '
Okay, Dr. Karimi, can you hear us? I think then we can continue to the next session. Then when we are ready with Dr. Karimi, he can do his presentation later. Dr. Karimi? Okay.